Today, I'm joined by Dr. Partho Sengupta, Chief of Cardiology and Associated Editor at the Journal of the American College of Cardiology, Cardiovascular Imaging. Dr. Sengupta, as a leader in the field of AI in cardiology, what is it do you think that clinicians really need to know about AI?
Thank you, Gary, for having me here. And this is a tremendous time that we are all in. This is really an inflection point because AI is going to enable us to solve some of the critical needs and challenges that we currently have. Number one is the amount of disease and the burden of the disease in the communities and in our clinics is just increasing, and we don't have enough time to be able to take care of all these patients. So how do we improve the efficiencies in our and throughput through our labs and free up time for higher caliber activity, particularly the art of medicine and the ability to connect with the patients is something that we all started off with and is probably required to be restored back. But there is a method or a mechanism that needs to be placed in, and I think AI is going to help, particularly with all the tools in doing the automated measurements and the techniques, particularly right now, that are prevalent and very rapidly coming into the clinical practice of automated diagnostics and measurements and contouring and freeing up time from all these activities is a great blessing, in my opinion. And I think there is absolutely, I believe that there is fairly strong consensus in the scientific community that this is the direction to move towards, to embrace AI-based techniques for automated interpretations and augmenting us. So you're not replacing a physician. So you're augmenting us. You always have an ability to correct the AI related measurements. So you can free up the time, don't have to do it manually, free up the time and do it an augmented way so that you look into the decision, agree, disagree, but ultimately you get an elevated information, level of information, and free up a lot of time for more critical assessments, particularly when you're doing your echocardiography. So that's the number one approach that is here, is going to stay, and is the only way forward to make more time for clinical activities that you're really interested to do, number one. Number two, I'm equally very thrilled by an ability to understand diseases in new ways. And this is an area which is in a slight infancy, I would say, because it means you can use new techniques to understand diseases, new techniques to understand your images. There is hidden information beyond the images. How do you extract that information? And again, be able to understand the disease patterns or the phenotypes that are otherwise not well understood. So that area is very important. And why is it important? Is because that's an area where experts are able to connect the dots between the images as they're looking through the images. Sometimes they intuitively pause, they're looking at an image. They can sometimes not say exactly what's wrong, but they feel that something is wrong. So this is not very uncommon. It happens all the time when you're reading with an expert. They look through a series of images and they make an integrated, intuitive judgment, clinical judgment of what that disease is and how that patient should be treated. And this aspect can be visited more scientifically in a way so that you can practice the medicine like an expert would otherwise do. So there's an ability for AI techniques to learn from the images and present to you information, the hidden information, which otherwise an expert would integrate together. And the ability for a novice or a person who would otherwise would miss out on some of this information is the next level of change that we will see in very near future, of extracting information from images and understanding diseases like experts do, so that there could be more standardized interpretation. Or even if the decision support tool that is alerting you to the presence of a phenotype, let's say amyloid or hypertrophy, you can then go back and interrogate and ask, explain me what is the reason you're calling this as an amyloid? And it'll come back and tell you, well, I feel the septum is thickened so much, and I feel that the left atrium is bigger. And all of this, when you connect it together, it looks amyloid is a very important possibility. So there's an explainable AI concept that is emerging, which is going to be the next change that we will see very soon in our clinical practice. And it will take away the black box out of the AI into an explainable AI, so that you're going to be more you're more able to understand the AI decisions and then incorporate that in your clinical decision making. And third thing, Gary, which I really feel is going to be the more important aspect, is the research in AI. In fact, AI provides us new opportunities to phenotyping diseases, connecting the dots from the clinical stories from EMR right across multiple imaging modalities, and be able to risk predict the future. So being able to do that seamlessly through different models is a very fertile area for research. And another area of research that is coming up very quickly, and it's called as synthetic modeling. So when you take a decision for a patient to do a surgery or not to do a surgery, or a pharmacotherapy or not to do pharmacotherapy, you can actually do a shared decision with the patient, have the patient next to you, and look through the modeling and say, look, I'm going to ask you to go through the stages of how I'm going to treat you. Do you agree? Is this consistent with what you want to do? This is going to lead to so much of change in your quality of life, and this is going to avoid an imminent danger of a heart attack to happen. Is this something that you want to do? And the patient may agree or not agree to it. So this decision-making process needs time. So we need to free up time for all this high caliber activity with the patient, connect with the patient, and do a decision-making. So the more research is going to happen in the future on individualized medicine, personalized medicine, only based upon the freeing up of our time and being able to execute some of this using some of these AI tools. So I think these are some of the roadmaps, and I'm really excited about the opportunities that are coming up in front of us.
No, thanks, Dr. Sengupta, and I agree completely. I think from my point of view, you kind of described it there a little bit. Often when people refer to artificial intelligence, AI, they have this perception that there is some sort of, pseudo-cognizance or decision-making or understanding behind the process, which I think could reflect or cause some concern, I guess, in the clinical community, which I think is a misconception for AI, because, at the end of the day, from my perspective, it's just an additional step down the road of what we would call advanced statistics, right? So you started out with the t-test, and then, we started to use logistical regressions for outcomes correlations and things like that. And now we're just down the road that we just have much more complex statistical techniques to, in the end, understand much bigger data, much more subtle data. And as you were saying, it comes down to really providing some kind of objective, quantifiable measure to these subtleties that up until now have not been easy to describe or relay in a quantitative sense. And AI is just another tool now, you can call it a statistical method, that allows it to do it. So there's a key element that it actually isn't making decisions and actually isn't intelligent at all. It's really just a way of describing something in a quantitative manner, as you've just said. So I wonder if we think about that in a little bit of context. I think there are concerns that the clinical community feel when they think about AI. And I wonder if you've come across or know of what some of these concerns are, and what we could be doing to overcome some of those concerns.
Yeah, I think, Gary, you make a very good point. So I think the concerns from the clinical community and some degree of skepticism is welcome. I would actually urge people not to accept anything until you use it, until you validate it, and you make sure that it is working. And in fact, if it's not working, tweak it. Work with the AI techniques and many things. Upfront, we ask for certain level of validation. I think the same thing, the AI needs to go through the same degree of clinical scrutiny. So yes, AI offers an opportunity to standardize, develop tools for understanding diseases. But number one is that if some degree of skepticism and healthy skepticism is welcome. And in fact, when we recently looked into AI models, we started proposing a sets of guidelines. There's a checklist when you develop guidelines on how you should construct an AI based approach. And the last step in that is called as a validation, when you want to make sure that your AI tool is working well. And that's a very important step. And in fact, if any tool that you're going to use, you ask for the validation step to be in multiple external sites. In your own environment where it was developed, it may work well, it may not work in an external environment. So you may need to tweak it so that it works in different environments. So multiple environments, multiple ethnic races, topographical locations, geographical sites. So an AI tool that is well developed should work in all these places. And those are the validation steps that you should look for whenever an AI tool is presented to you, how well it has been validated. And if it has been validated, I think that should give you sufficient degree of comfort that it will work well. And once you start working on it, I think people will become more and more comfortable about the concept. The next aspect I really want to emphasize is that I believe that you use AI and tools for AI for augmenting your decision. You're not replacing yourself, at least in those activities where you think they are important for clinical healthcare delivery. If it is a AI model that is substituting a clinician, then you need to have a really, really high bar of performance, clinical performance. Can you use it? Yes, you can use it. For example, making an LV outflow tract measurement or doing a contouring. Well, these are activities which are low risk activities. You can free up a lot of your time, measurements. And yeah, if you see a performance is very good, your correlations with your expert annotations and expert measurements are very good, you start accepting them. So there's not much to lose in them. But what we are not saying that you completely replace your role, you're augmenting yourself, you're participating in the evolution and freeing up your time. So when you're looking at the tool, the first question therefore you should ask, is this something that you're going to replace one of your action? And if that's the case, how good is the performance and how well it has been validated? And if it's something low hanging fruit, something that you really don't care about, not repeating it in your busy day-to-day life, then once it is well validated, once it has been shown it works well, you shouldn't worry about it. You should accept it. When it comes to make more therapeutic and risk prediction and more higher caliber activities or decision model, that's the step, which is coming very soon. These steps are decision-making tools are going to come very soon. There we are going to use it for augmenting your decision, not replacing you. So that should allow you comfort. And as I said the third time, whenever an expert gives an opinion or any other of your colleague gives you an opinion, you always ask, why did you say so? Hey, you looked at the image and you called it out. Why did you think it was that way? Same way, ask the AI, why did it call out certain decision? Ask for explainable AI, and those concepts are going to help you to start, accepting some of these tools in your clinical practice.
I mean, I think you're completely right. And, you were mentioning there that there are some key areas that, are going to really, if you don't use this technology, are going to really impact your practice, burnout, throughput, efficacy. So I wonder if we expand a little bit on that, what do you think the current key challenges are in echocardiography specifically? And which of those do you think are particularly being addressed through the application of AI today?
Yeah, so Gary, I mean, echocardiography has expanded itself in the sense like now you have also pocket ultrasounds, and pocket ultrasounds, I believe, are modern ways to do cardiovascular consultation. I really don't understand why a patient who's coming to a modern cardiology clinic should not have an imaging. Why would you want to percuss, auscultate, palpate? Not that you cannot do that, but we know that they are not standardized and they don't work well. And there's a lot of variability, extreme levels of variability in that. Why would you not have an imaging done in the clinic, pocket ultrasound? In my opinion, every single patient who walks in and has a question which could be related to cardiology should get a extended physical examination using pocket ultrasound, and that should allow us to increase the throughput of more appropriate echocardiograms. I think there's a lot of latent disease out there in the community. We know that cardiovascular disease doesn't happen just with the onset of symptoms. Symptoms is a sequelae of a disease that develops and finally the patients. Why is it that we, for example, in oncology, you always look out for a subclinical cancer, right? But in cardiology, you don't look out for that buildup and you just wait till it goes and causes a symptom. It's a total paradox, in my opinion. We need to move towards efficiency using newer tools. For example, you can use wearables, you can use ECG. There's an amazing amount of work that's being done right now on how do you use ECG more efficiently with AI tools for appropriate imaging. Using in your clinics pocket ultrasound, using AI tools there. I mean, there are companies, there are vendors who are using AI and training even a novice or a person who's not a sonographer who can acquire images using AI tools. And if you see a problem there, then doing a more appropriate echocardiogram. I can tell you that you're not going to cut down the number of echoes to the echo lab. You'll have more appropriate echoes and reduce the inappropriate echoes. Now, 20 to 30% of echoes that are done in a clinical practice, I can do many times are normal, and there's hardly anything. Why should you do those echocardiograms? Reduce those numbers and increase that more appropriate. Spend more time with your quality of the images. Use AI tools, improve the efficiency. This is the paradigm that has to evolve, and I think is immediately needed. I'm not sure, Gary, if I answered your question, but I think this full continuum of evolution, finally at that very end, of course, to also discover the therapies, right? I know that the field of computational modeling, at least I know that FDA is working with many companies. We've seen in structural heart diseases where you can put in a valve on an image, right? Treating an image before you treat a patient is a great concept, because I think it allows you to develop experimental evaluation of the therapies that you're going to do. And none of this is going to be possible if you don't use AI tools. So this is a full change, a paradigm change that is coming and is, in my opinion, imminent. And it's very exciting, to be honest.
No, I agree with you completely. No, thanks for your views on that. I think, we can all agree that, AI is here to stay and is really making significant impacts into medicine, and particularly echocardiography. So much so, Ultromics is really looking at, disease identification, prediction as early as possible, with the main aim, of pathway transformation, really. And as you can see, with all of these AI technologies that are coming in, the pathways that we recognize in cardiology are going to change. And the places that we assess patients and the mechanism by which we assess patients is going to change. And I think ultimately that's going to mean more appropriate patients are going to see the appropriate clinician at the right time, at a time when they can do something about disease prevention rather than necessarily treatment. For example, I think this is really the way medicine is going to go, and really being spurred on by the application of AI. And I think that's my view, and I'll close off on that view, and I'll allow you, Partho, to give us one final thought, really, on your position of AI and echocardiography.
Yeah, I think, Gary, you make a very important point, that this cannot happen without the entire community come together. So the academic, industry, and federal sources, all of us need to come together and collaborate on this partnership to make this evolution eventually possible. And thank you very much for being so forthcoming and allowing some of this academic industry collaborations to happen. And this is very wonderful to see.
Thank you.
Thank you.